Good day. Our topic for today are the drugs that weaken the bacterial cell wall, your cephalosporins, carbapenems, vancomycin, telabancin, aztreonam, and your fosfomycin. So your cephalosporins are beta-lactam antibiotics similar in structure and actions to your penicillins. These drugs are bactericidal and often resistant to beta-lactamases and active against a broad spectrum of pathogens. So their toxicity is low, and because of these attributes, your cephalosporins are bactericidal and they attach and bind to your penicillin binding proteins or your PBPs. They disrupt cell wall synthesis and they also activate autolysins or your enzymes that cleave bonds in the cell wall. And now, your principal cause of cephalosporin resistance is the production of beta-lactamases. These are the enzymes that cleave the beta-lactam rim and thereby render these drugs inactive. So beta-lactamases that act on your cephalosporins are sometimes referred to as your cephalosporinases. So most first-generation cephalosporins are destroyed by your beta-lactamases. Your second-generation cephalosporins are less sensitive to destruction, and your third and fourth and fifth generation cephalosporins are highly resistant. Ceftaroline, a fifth-generation cephalosporin, has demonstrated activity against your MRSA or your methicillin-resistant Staphylococcus aureus. Here are the classes of your cephalosporins. We have your first, we have your second, third, and fourth, and fifth generation. So first, we have your first generation cephalosporins represented by your cephalexin. So they are highly active against gram-positive bacteria. So the first generation agents have modest activity against gram-negative bacteria and do not reach effective concentrations in your CSF. Now, for your second generation cephalosporin, example will be your cefoxitin. So they have enhanced activity against gram-negative bacteria. Now, for your third generation cephalosporins, example will be your cefotaxime. They have a broad spectrum of antibacterial activity. So some third generation cephalosporin, example will be your ceftazidime, has important activity against Pseudomonas aeruginosa. So in contrast to your first and second generation cephalosporins, the third generation have can reach clinically effective concentrations in your CSF. Now, this your CPP, the only fourth generation cephalosporin, they are highly resistant to beta-lactamases and has a very broad antibacterial spectrum. So activity against Pseudomonas aeruginosa equals that of your ceftazidime. So the penetration to your CSF is good. Now your ceftaroline, example of your fifth generation cephalosporin, has a spectrum like that of your third generation agents but with one important exemption. Ceftaroline is the only cephalosporin with activity against your MRSA. And now for the pharmacokinetic properties of your cephalosporin. So because of poor absorption from the GI tract, many cephalosporins are administered parenterally. No, so cephalosporins distribute well to most body fluids and tissue. So penetration to the CSF by your first and your second generation is unreliable. In contrast, CSF levels achieved with third and fourth generation cephalosporins are generally sufficient for bactericidal effects. So for elimination, um, practically all cephalosporins are eliminated by your kidneys. Exemption will be your ceftriaxone. So ceftriaxone is eliminated largely by your liver. And now for the drug interactions, your probenecid delays renal excretion of some cephalosporins and can thereby prolong their effects. So this is the same interaction occurs between your probenecid, and your penicillins. Now, your alcohol, um, uh, wherein the two cephalosporins, your cefazolin and your cefotetan, can induce a state of alcohol intolerance. So, if a patient taking these drugs were to ingest alcohol, a disulfiram-like reaction could occur. And calcium and ceftriaxone, combining the two of these can form potential fatal precipitates. So another adverse effects would be your bleeding. So two cephalosporins, your cefotetan and your ceftriaxone, can cause bleeding tendencies. The mechanism is reduction of your prothrombin levels through interference with vitamin K metabolism. And now for your prototype drugs. So the prototype drugs for your cephalosporins is your cephalexin, for your carbapenems, your imipenem, and we have your vancomycin that will be discussed later on. So here are your cephalosporin dosages. So with the exemption of your ceftriaxone, cephalosporins require a dosage reduction in patients with severe renal impairment. Now let's go for your carbapenems. So they are beta-lactam antibiotics that have a very broad antimicrobial spectra, although none is active against MRSA. And here are the list of your carbapenems. So we have here your imipenem, which is active against most gram-positive and gram-negative aerobes and anaerobes. We also have your meropenem, which is widely used for gram-positive and gram-negative aerobes and anaerobes. We have also have the ertapenem, most used for gram-positive bacteria and anaerobes, and your durepinem for your gram-positive, gram-negative, and anaerobic bacteria, including your Pseudomonas aeruginosa. And for the other inhibitors of cell wall synthesis include your vancomycin. So they are indicated for Clostridium difficile infection and MRSA infection. And they are used as a treatment of serious infections with susceptible organisms in patients allergic to penicillins. And the major toxicity is renal failure, and vancomycin does not contain a beta-lactam ring. Now, for the mechanism of action, so like the beta-lactam antibiotics, vancomycin inhibits cell wall synthesis and thereby promotes bacterial lysis and death. So, in contrast to your beta-lactams, vancomycin does not interact with your penicillin-binding proteins. So, it disrupts the cell wall by binding to molecules that serve as precursors for cell wall biosynthesis. The antibacterial spectrum of your vancomycin includes your gram-positive bacteria, Staphylococcus aureus, epidermidis, including the methicillin-resistant streptococci, penicillin-resistant pneumococci, and your Clostridium difficile. So as stated earlier, the major toxicity is your renal failure, and there is a risk dose related and increased by concurrent use of other nephrotoxic drugs, such as your aminoglycosides, cyclosporine, and your NSAIDs. So rapid infusion of vancomycin can cause a constellation and disturbing effects, which is your Redman syndrome. So Redman syndrome includes flushing, rash, pruritus, urticaria, tachycardia, and hypotension. So these effects may result from the release of histamine and can be avoided by infusing your vancomycin slowly over 60 minutes or more. So thrombophlebitis is also common for vancomycin, and rarely vancomycin causes immune-mediated thrombocytopenia, so a condition in which platelets are lost and spontaneous bleeding results. Now, the intravenous dosing of your vancomycin, intermittent infusion over 60 minutes or longer, and the dosage is around 15 to 20 milligram per kilogram every 8 to 12 hours, and the loading dose may be up to 25 to 30 milligram per kilogram. Now, for your telavansin, so these are lipoglycoproteins, synthetic derivatives of your vancomycin. They are only against gram-positive bacteria and they inhibit bacterial cell wall synthesis. Your telavansin also binds to the bacterial cell membrane and thereby disrupts membrane function. So, telavansin is approved for IV therapy for complicated skin and skin structures and infections and hospital or ventilator-acquired pneumonia. So, your Staph aureus, Strep pyogenes, Strep agalactae, Strep agenesis group, and Pterococcus faecalis are part of the antimicrobial spectrum of your telavansin. Now, your telavansin causes kidney damage in 3% of patients as indicated by increased serum creatinine. And it can also prolong the QT interval. And your telavansin is supplied as a powder for reconstitution, followed by dilution to a final concentration of 0.6 to 8 milligram per ml. And now, your Astrionam belong to a class of beta-lactam antibiotics known as your monobactams. So the mechanism of action, it binds to your PBP3, thereby like most beta-lactam antibiotics, the drug inhibits bacterial cell wall synthesis and thereby promotes cell lysis and death. So the drug does not bind to your PBPs produced by your anaerobes or gram-positive bacteria. So Astrionam has a narrow antimicrobial spectrum, so being active only against gram-negative aerobic bacteria. So susceptible organisms include your Neisseria species, Haemophilus influenza, Pseudomonas aeruginosa, and Enterobacteriaceae. So they are highly resistant to beta-lactamases and therefore active against many gram-negative aerobes. So Asteriornam is not active against gram-positive bacteria and anaerobes. So Asteriornam is not absorbed from the GI tract and must be administered parenterally, either IM or intravenous for systemic therapy. The concentrations can be achieved in the CSF, and Asteriornam is eliminated by the kidneys. And in addition to being administered IM or IV, Asteriornam can be inhaled for delivery directly to the lungs. This route is used to treat Pseudomonas aeruginosa lung infection in patients with cystic fibrosis. And lastly, for your fosfomycin, so it is a unique antibiotic approved for single-dose therapy in women with uncomplicated urinary tract infections caused by your E. coli or Enterococcus faecalis. So the drug kills bacteria by disrupting synthesis of your peptidoglycan polymer strands that compose the cell wall. So fosfomycin is supplied as a water-soluble powder in single-dose 3 milligram packets. So dosing may be done with or without food, and the symptoms of your cystitis should improve in 2 to 3 days. And that is, thank you for watching.